My name is Dr Maumoon. I'm a consultant psychiatrist. I've been working in Holmale Hospital as a medical officer before I went for specialization. And after specialization, I joined here as a consultant psychiatrist. And when I joined, it was around August 2022. There was no mental health department. And after I joined, the hospital kind of got together and we designed a small space to work as a mental health center. And with the affiliation from Foreign Hospital, we got the center going on October 10th, 2022. So this is our second year of providing service. I did my specialization in Nepal Teaching Hospital, Tribhuvan, Kathmandu. And since coming here, I've been working. Mostly, we only provide outpatient services, OPD. But at the same time, we do see the patients who are admitted if they have a psychiatric complaint and patients in the emergency. We do also visit the local schools and mostly we do awareness sessions on common mental issues facing school children and some uncommon symptoms that might be missed. We also provide treatment to the children under state care in Fiyawati and also the halfway house that is in Holumale. And even children under state care in the islands, they do get referred here. So I have been really busy since the last 2 years. Yeah.
And what's the demand like for services at the hospital?
So generally in the mental health center, most common consultation is for anxiety disorders. Not because it's the most common, but anxiety kind of makes you run to the hospital to get treatment. So these are the people who come to the hospital to get treatment. So most of the psychiatry OPD is for anxiety, different types of anxiety. But there is high demand for assessments, mostly for autism, ADHD assessments, and sometimes IQ assessments, and sometimes personality assessments as well. And then psychologists provide different types of therapies. There's cognitive behavioral therapy and dialectical behavioral therapy. So these two are talk therapies. And from our center, we just provide the talk therapies only. We do have a different center in the hospital for children, for occupational, speech, and behavioral therapy. So the highest demand is for psychiatric consultation. There's a long waiting list. And then it's for psychological therapy and assessments.
You mentioned a long waiting list, and that's a common complaint we hear as well, that the queues are very long if they're trying to get an appointment. So maybe you could share what the reasons behind that are.
So it's a very commonly asked question. Why are the psychiatry consultations so long, or why is there a long queue to see a psychologist? So first we have to look at the question and we have to step back and see what the overall picture is. When a patient initially comes to a psychiatrist, the complaint that they might give me might be something very small, like, I can't sleep. I haven't been able to sleep for the last few weeks. So if you take that complaint at face value and just give medication, you're missing out on the cause of what's happening or what's behind all that. So you have to take that extra time to dig a little, what else have you been facing? What are the other symptoms? What stresses are you facing? How is your, family and friends and social support system like? How was your childhood? And the more we ask, we find out what led to this sleeplessness. And sometimes there's childhood trauma, there's some ongoing stressor that is going on. So it takes time to gain their confidence. It takes time for them to open up and talk about things they haven't really talked about before. So we do spend the extra time to get to know what's really going on. So that's one thing. And secondly, when we outline the treatment, when we prescribe medication or counseling or therapy, we have to spend time to gain their confidence and make them understand what we are trying to achieve here and make them confident in order to follow through with the medication. That again requires time and more questions to rule out any medical condition that might be, causing these issues. So that's anywhere between half an hour to 45 minutes right there for a new patient. Mm-hmm. So we can't just afford to rush through patients because we'll be missing on a lot of things, missing on the real issues they're facing and missing out on gaining their confidence. So we can't be seeing as many patients as other departments if we are to keep the quality of care that we need. And at the same time, the therapy given by psychologists, again, we're talking about 1 hour per patient. And most of those talk therapies like CBT and DBT, we are trying to get them to change thought patterns, behavior patterns, defense mechanisms, and things that have been around for a long time. So those therapies, you have to give multiple sessions. So it takes a long time to make an impact. So the time that we in our department spend with patients is a lot more when you compare with other departments. So the question is why the queue is long. So one is it takes time. The other one is when you look at society as a whole, not every patient who comes to see us necessarily has to see a psychiatrist. Initially, as soon as there's onset of symptoms, if it's a school child, I think the teachers and the school counselors can notice that and take the appropriate steps. If it's at home, the family members can start talking to the patient. If it's at a workplace, maybe the supervisors should get to know. And there should be intervention at that level. And if that intervention is not working, then we can go to counselors or junior doctors, nurses, or healthcare professionals in hospitals and try to get an intervention at that stage. So what is really going to make a big impact on the long queue is a stronger social public health system with a lot of counselors, so that most of the patients are treated in the public health setting. And those who are really severe and serious, they go to the next step of seeing doctors and then finally specialists. But what happens in our country is that the mentality is that the higher up the food chain you go, the better treatment you'll get. That is not necessarily true. So the pyramid needs to be, pyramid shaped rather than upside down. So public health system is the main impact we can make. And we have to realize that the challenges we face are unique. We can't just copy a model from another country. We are geographically challenged. A sea separates us. So even the specialists who are in one island might not be able to physically visit the neighboring island if the weather is not good. And another challenge is the stigma and public mentality of seeing a psychiatrist, which might make people hesitant to see. So that also takes time to gain their confidence. So different challenges, but mostly the quickest impact will be from improving the public health system.
You spoke about stigma, and even in this day and age, it's quite common in our community. So what would be your advice to, overcome this stigma? What can we do as individuals to help that?
I like the way how you phrase the question, like what can we do as individuals? So this is not the first time that illnesses have been stigmatized against. Even since a long time back, people were like prejudiced, stigmatized against like HIV, tuberculosis, leprosy, and some people would be, ostracized. They would be separated from community, and people would blame different factors, like, supernatural factors, on their symptoms. But our healthcare workers, they did a lot of work. They visited the public, they raised awareness, they talked to people, and now those people live among us. They're free, the stigma is very low, discrimination is low. So we can do the same thing. The mentality is that, if it's a mental illness, it's not necessarily an illness, but it's rather a failing on our part, or failure of our, we are not trying hard enough. It's maybe due to laziness or a moral failing. But when our body is facing stresses on a constant basis, actual biological changes happen. These changes bring about actual biological symptoms. So, mostly to do with our thinking and our ability to deal with stress. So, these are actual medical illnesses. So, we have to accept that it's not due to our moral failings or due to, laziness, but actual illnesses that we are combating. And the negative stereotypes we give actually prevent people from seeking help. And the other main, one of the questions I get most commonly is, somebody told me that the medication that you give is, it's going to be addictive, or I have to take it for a lifetime, or it's going to have severe side effects. And it's always somebody told me, you should not take this medicine. So a lot of people are hesitant. But our medication that we give is the same as medications given in any other department. And we do have medications that are not addictive. Only one specific group of all the meds we give can be addictive, and we don't give it to that extent. And we have medications with minimal side effects. And it's only chronic illnesses like schizophrenia and bipolar that we have to give long-term medications. Anxiety, depression, we just give it for a specific set of time, and when the patient improves, we stop it, and there are no long-term side effects. So that is one of the wrong beliefs in the public that we have to combat.